Okay, so this is reporting non-solid cancers and the consequences, and Professor Grannis and myself will be moderating this. Fred, take it away.
Okay, well, we've been talking about management of non-solid nodules at this conference for 25 years. But I don't know that we've ever talked about reporting non-solid nodules, and that's what we're going to shift gears and do today. Why is that important? Well, when screening started, the critics of screening came out with this long list of horrible things that happen to the patient. A person becomes a patient. He gets medicalized and he's tormented by terrible anxiety by the screening process. And we've learned over the years that that's not true. That patients who are at high risk and who are well screened in an algorithm, they do just fine. They don't have a lot of anxiety. Dan Raz and other people have done systematic reviews, and we know that. But now with the 21st Century Cures Act, as Dr. Wolf and Dr. Altorki mentioned, there is some pressure to start using the cancer word when we see non-solid nodules. And so I want to start out by asking Dr. Kazerooni. Yeah. Oh, no, but if you would, when you speak first, would you please introduce yourself in the interest of time?
Sure, I'm Kazerooni. I'm a cardiothoracic radiologist at the University of Michigan.
So, Dr. Kazerooni, this is a 7-centimeter lesion that's found on a baseline CT scan. Do you have any problem using the word cancer in your report? Okay,
Absolutely not.
That's easy. Now, this is an 8-millimeter solid nodule that Rick Avila has been. And does anyone have any trouble using the word cancer on an annual follow-up report where that nodule was not present before, and now there's a new ragged-looking 8-millimeter lesion? Any problem with using the word cancer?
So you kind of changed the paradigm as you were talking about it. So first it was a nodule, then it was one that's a new nodule, then it's one that's ragged looking.
Yeah.
So it really is. So you're talking about an irregular new 8-millimeter nodule.
Yes.
Just to be clear. Yes, I would use the cancer.
Okay. Now, here's another lesion. This lesion you can see through. Take that.
Love the visuals.
That nodule has, there's no solid component to it. The question is it appropriate to use the word potential adenocarcinoma in that lesion? And so.
Yes, I think so. I think as a radiologist, we're part of the diagnostic continuum. We work together as a team. I think if we don't use the cancer word, then it may cause patients to potentially not follow up with, if we're going to do serial CT imaging for these. I think it's important to be upfront with what we're thinking. Our pulmonary medicine colleagues put it in their notes when they see the patient, as do our thoracic surgery colleagues. And I think it's important for radiologists to be part of that team and use the same language and nomenclature.
Now, is that opinion based on the 21st Century Cures Act, or were you doing that before?
Before.
Okay. So now let's bring in, we have a distinguished pulmonologist, Javier Zulueta.
I think you do have to report what you see, and the radiologist has to help us in determining what, possibilities are. However, you can imagine the complexity of arguing that or discussing this with the patient. And today, the cases that we saw on the panel before are just here. We couldn't agree. You got 7 different opinions on how to manage these nodules. Imagine that discussion with the patient. And the patients come, by the way, now with, the Fleischner guidelines say if there's a 2-millimeter growth or whatever, or you should consider resection. So all that is really, really complex. But I think the radiologists have to report on what they see and include a differential diagnosis like they do with any other finding.
Raja.
Hey, Fred, what's this 21st Century Cures Act?
Well, it's I guess maybe the right person to answer that question is Lee.
I'm going to defer to you on that as how you interpret it, rather than how we would interpret it, because we look at things totally differently.
Well, but the 21st Century Cures Act has a provision in it that has a potential fine of $1 million for violation of the provisions of the act. So I think that should wake everybody up.
Is this something that was passed by Congress?
It
or-
was passed by Congress in 2016, and it has just gone into effect now in 2022, 2023. David, have I put that right?
I think Professor Mulshine is the expert here on the Cures Act.
I think you're doing great, Fred.
Okay.
And
All right.
the Cures Act is an effort to ensure that any information that is medically relevant, that's in the chart and being discussed on a patient, is also available to the patient and is explained and options are defined. And the consequence of that, I think, is manifested in this recent thing from the FDA on dense breasts. You know, dense breasts have been problematic, and women are very upset because it sounds like they're having the same discussion that Javier described for small nodules for dense breasts. You know, a lot of people had them. They were now reported on. But then what to do about it was very, very problematic for individuals. So FDA stepped up and said, you have to address this.
It's very interesting how it's played out in the field of radiology and pathology. Right? Reports are immediately released to the patient portal upon the signing of the report. And as was commented earlier, patients are getting their information before the ER doc comes in to see them, before they're seen in clinic by the physician. And you may be in surgery, you may be doing procedures, you may be off that week, whatever it is, but you're not always necessarily available to manage the information that is coming to patients immediately. We've done some studies about patient preference in receiving their reports, and it's very heterogeneous. The majority of people do want to receive that information. Some patients have there's a subset that's described, they want to be prepared for the discussion ahead of time before the physician comes in to see them, and they really want that information. But there is a subset of patients who would rather not. And we don't really differentiate. We have this, process, everything goes out immediately, and we don't really tailor it to patient preference. And legally, we're not allowed to modify that to patient preference unless we believe it is going to immediately harm the patient. If you had a known suicidal patient who's had multiple suicide attempts, you could justify withholding the information. Or if the provider is having a talk with the patient, orders that CT scan, whatever that test is, and the patient provider discussion, part of it is the patient wants to wait. The physician has to document it in the record that they've had a discussion. The patient is asking that the information not be released to their portal, and then they can click a box in the order for the test that they've had that conversation. But it's very clear that other than that, some certain specific circumstances, genetic testing is one of them, all of our reports are going out to your patients immediately.
So when we see these lesions on a CT scan, as on a screening in particular, we have particular recommendations, and the recommendation is come back in a year. The recommendation or the guidelines don't say come back in a year because, adenocarcinoma spectrum. Should we be putting that in every case? Now, you can argue that, well, we can sort of say, well, we're not sure that it's an adenocarcinoma spectrum lesion, but there's a high level of confidence when we see these lesions. I mean, I'm sure what they are. If I see it in 2 years and it's slightly grown, I'm positive what it is, that it's going to be one of these lesions. And so the question I have is, should this now become our new guidelines? Should we be saying you must say when you see these lesions, not just come back in a year, come back in a year because you have cancer? I mean, this is really challenging. So
Well, I mean, so we have Dorothy you're not in the United States. You don't have to worry about that $1 million fine. What do you tell your patients in your reports who have a non-solid nodule that may be growing slowly or is found on initial presentation?
I would not mention the word cancer.
Okay. What about other I mean, do we really know the natural history of non-solid nodules to be able to say that they're all on the adenocarcinoma spectrum? Raja?
I mean, it's not common, but every once in a while you take one out and it's not cancer.
But you have some that disappear completely
Yeah.
and some that never grow.
The best
Okay.
evidence comes from I-ELCAP, from David's paper.
Okay.
Showing that, all the resected non-solid nodules in the I-ELCAP cohort were adenocarcinoma spectrum type lesions. But many of them, I don't remember exactly the percentage, David, but maybe 80% of them had some stromal invasion according to the pathology. How do you explain to a patient that that's not dangerous?
David's series are particularly unique because they, by the time they get to be resected, they've already passed several milestones of growth and all that. Nobody is arguing about that. The problem is, I have a patient who had lung cancer resected right upper lobe. Okay, he has now a 1 millimeter non-solid nodule in the middle of his left upper lobe. And it's called, sometimes the report states a differential, sometimes it's pretty definitive. How do you convince a patient? The patient now is very nervous and wants a biopsy or stereotactic radiation, or wants you to do something about this 1 millimeter centrally located.
1 centimeter.
1 centimeter, yeah, 1 centimeter. So that is the challenge here. I think there are data from the Far East, by the way, that are exactly what Fred says. They're not in a screening program, so they don't have that strict scrutiny that David and Claudia put them under. And about a third of these go away. I don't think that you lose much by actually sort of fudging the case.
To add evidence, we have Rowena's paper showing the review of 700 non-solid nodules in the literature, and the survival, the 5-year survival rate of those that were resected was 100%. So yes, I mean, we do know that we're in safe grounds here, but still, my question is, and I have to do this every week. First of all, I have to do it in the tumor board, lung nodule board. We have the same discussions that we had before. Nobody agrees on the final recommendation for the patient. And then I have to go to the patient to tell them this. And that is very complicated. And many patients with family members come in and they're very sophisticated these days. They know a lot. And they come with the Fleischner Society guidelines or lung rads, or you have to tell them, no, lung rads is for screening. It's not for this. I mean, that kind of discussion I'm having with patients.
You're a busy guy.
Is there any data that anyone knows? We know that screening is, the way it's performed in I-ELCAP is safe. The patients are not freaked out by it. They don't have terrible anxiety. But do we know what happens when you use the word adenocarcinoma in your report? Does that drive further anxiety? Ellie, you seems like you would have information on that.
Well, I think, just approaching radiology and what we put in our report, if somebody has a 5 centimeter aortic aneurysm, I'm not going to say, oh, it's a 5 centimeter dilated aorta and not use the aneurysm word.
Right.
So why in this circumstance would I not use the maybe on the adenocarcinoma spectrum?
Well, but that's not the question. The question is, does that word stoke anxiety in patients?
Absolutely.
Okay.
Absolutely. And that is a good thing, because if they're not anxious about it, they may not come back for follow-up. We lose them, and then we lose that opportunity for early
I
intervention.
think what's driving this whole discussion, though, is the surgeons have come to me and say, man, you tied my hands. Now I'm almost forced to operate on something I don't want to operate on. We'd be safe following it. So every time let's get the surgeons' opinions on this, and then.
Before we do that, I would ask, from pulmonary and thoracic surgery, aren't you having that conversation with the patients about it could be an adenocarcinoma? We may or may not should take it out, and what the risk and benefits are?
Andrea?
How is it any different?
Short answer.
First of all, the patients get anxious about everything in New York. I mean, this may differ in California, but
no, it's made over.
you don't even have to say aneurysm. I have atelectasis. What do I do about, but to clarify, yes, we need to be having those conversations. I think the challenge with this law is that this information becomes available at like 2 a.m. somehow. The report gets released by the system, and the level of anxiety is sometimes hard to manage. I don't really know what the right answer is. I appreciate your point that you need them. I feel like the people you need to nudge, it almost doesn't matter. I don't know that it would be interesting if we could assess whether using that language actually improves the reliability of follow-up. It's a very important point. I just think the people it impacts are so neurotic that it doesn't even matter.
New
They're
York
they're
may be
already
a
in
little
the
different than the
office.
Midwest.
At some point, Lee, we've got to get you involved in this here.
Let me start by reducing the amount of anxiety in the room. Speaking as
Remember, Lee is a malpractice attorney.
So, as background, I went to NYU Med, NYU Law School. My practice has anything to do with medicine and the law. So I've run imaging facilities. I represented many positions before state boards. And I also do malpractice, and I've done it on both sides of the fence. So let me say, listening here as I have over the last couple of days and over the last umpteen years, the only way a patient gets to see a lawyer is when you lose control over that patient. And the more information you give to the patient and the more you document that information that you've given to the patient, the less likelihood that that patient who goes to see a lawyer is going to end up in any sort of litigation. We also look at it, as do you, as to age factors. If somebody is 55 years of age and has been misdiagnosed, I'll use that term, with a lung cancer that's going to lead to death, that's going to be a different way we're looking at that patient rather than that patient is 85 years of age. What are the damages? Because being as fiscally minded as anybody else is, lawyers look at the damages and what they are going to get out of a piece of litigation. So the first thing that we would do is when we get a patient, it means that you have lost control of the patient. You can speak to the patient, they understand you, and people will come into me, and I remember a number of examples. They'll say, look, I've been through this, I'll sue Dr. A, I'll sue Dr. B, I won't sue Dr. C. And I'll say, well, Dr. C is the one who did most of the liability here and was most negligent. Yes, but that doctor spoke to me. That doctor was there when I had questions. I would not sue that doctor no matter what. So it's the communication that you give, the documentation in your charts that make a determination as to whether or not we would proceed if there were a situation that we might consider proceeding. So get your level of anxiety down. We're not totally bad guys. So it doesn't sound like we are.
So can I?
And I would add to that, people come to me and say, and they're very cynical as to surgeons. They say, anytime you're going to go to see a surgeon, they're going to want to operate on you. I know that is not necessarily the case, the majority of the case, though there are definitely exceptions to that rule. But again, it's communication. It's communication, documentation, and get rid of the lawyers. That's how you're going to do it.
So Ella, when you say in the spectrum of adenocarcinoma, you also have to say it could be inflammation. It could be something that we don't even know. They'll go away. You can't just use one part and
Agree.
not say the other part as well.
100% agree, especially the first time you see it. But if you're seeing it over time, I think that's different.
Dr. El-Torki.
Thank you. That last statement is really important. The way I talk to the patient is, it could be, but it could not be.
Mhm.
And that sort of gets you out of this, it is discussion, and then what do you do? And the legal advice was tremendous, but here's the scenario that happens. You say, well, we're going to follow it, and then it turns out to be cancer a year from now, and then for whatever reason, you sit there and say, well, Dr. Kazerooni is a radiologist. Are you a radiologist? Can you read those things? How reliable is your reading? And that's the conversation that sometimes happens. It is not necessary. I mean, maintaining communication is good if nothing happens. If something happens and the patient loses confidence in your initial consultation, which is we should follow it, it becomes problematic. I want to say that most of us in this room, I want to say all of us in this room, do not counsel patients based on the legal consequences. We counsel patients based on the harm that may come to them as a result of potentially unnecessary or bigger procedure than they need. And I think Dr. Kazerooni's last statement is absolutely what we need, is give us some space to talk our way out of it.
Well, it turns out that the 21st Century Act does give you some wiggle room. They have eight exceptions to this rule. And the first one is the preventing harm exception that says that this recognizes that the public interest in protecting patients and other persons against unreasonable risks of harm can justify practices that are likely to interfere with access, exchange, or use of electronic health information. Lee, does that give these doctors wiggle room to not use the word adenocarcinoma?
No, I do not believe so. I believe patients want information. And again, as I say, a patient doesn't come to see a lawyer until they feel that they cannot communicate with the physicians that they're dealing with, or they're getting false information. The typical example is you have a tragedy and you can't, and the first thing that the family will say to me, we never saw the attending. There was a mishap. There was that lung biopsy went wrong. Patient died on the table, whatever. We didn't see the physician afterwards. He never came in and communicated with us. So it's communication and documentation. I don't care what the lesions are and what the end result is. If it's documented in the chart that we've discussed it with the patient, they are aware that it's potentially a cancer. We don't believe it should be done anything at this point in time. We are following it with the patient and going to act when we should act. It's there in the record. And what am I going to do that with the jury? Ultimately, I have to go to a jury who's going to be most of the time on the side of the physician, because they all need physicians, and they want to see something that was done that was egregious. That is not egregious.
I think you have to think, if you put your hat, you try and sit in the seat of a radiologist who's reading an exam. And these exams just don't get ordered by pulmonary medicine physicians and thoracic surgeons who know exactly what to do with these and how to have that complicated discussion with patients. These exams come from primary care. They come from every specialist of every type. And they're users of this information. And if we don't, in my belief, if we don't interject that this could be cancer, and we say, you know, it's a ground glass nodule, do a CT in a year, and the primary care physician doesn't know that that could be cancer, and the patient doesn't hear that that could be cancer, my concern is that those patients may not get that follow-up. And if you're not in a system that has a tight nodule management program where you're following these patients, you have a nurse navigator making sure they come back, they're getting outside films and so on. If you don't have a tight structure for incidental pulmonary nodules, I think there is a lot of harm to be done by how other specialties outside the experts use this information.
So I have a couple of questions to follow this up with. So basically what you're saying is you're kind of using the C word with these lesions all the time. You know, that's one thing to comment on. The second thing is, Nasser, you wanted the sort of wiggle room where maybe it's inflammation or not. But, you know, when you see it over the course of a couple of years and it's growing, you know, my confidence as to what it is, it's close to 100%. You know, I'm positive what it is. So do we have to say adenocarcinoma, and should this be in our guidelines? You know,
if I may interject, David, the answer from my point of view is yes. If a patient is aware of the basic cancer as a potential diagnosis, then everybody is joined in a judgment decision as to what to do. And a doctor it was the original case on what physician's liability dates back to 1898. But in that case, it's basically a physician is not liable when they're using their judgment.
so we have two other radiologists in the room from other parts of the world. First is my former fellow, Ming Wu from China, who's going to tell us a little bit about what she thinks of this conversation.
Okay, thank you very much for so wonderful conference. I mean, in China, I think the non-solid nodule for treatment and diagnosis as big problems for, I mean, for surgeons over treatment. Yeah. In my hospital, I think surgeons and the radiologists are doing well because we have 7 or 10 radiologists trained at I-ELCAP came back. So we are doing well, I think. But in China, we showed improvement for non-solid nodule treatment and diagnosis.
Do you say on your radiology report cancer when you see them, or do you just say non-solid nodule?
We say non-solid, cut solid, and solid.
But
And
do you
follow.
think it's cancer though, or do you just describe the lesion?
Some radiologists described, then some radiologists it's a earlier period of lung cancer.
Okay,
Different.
thank you.
Okay.
And Dr. Fliegenhardt,
Thank
how
you.
do we do it in your part of the world?
So when we initially see the subsolid lesion, we'll do according to Fleischner, we'll do the 3-month follow-up to see persistence. And then, yeah, we do put the differential diagnosis or suggestive of an early adenocarcinoma in the conclusion. Our patients do not see the entire report, but after a number of days, they will only see the conclusion of the report. And these cases will be referred to the pulmonologist if they come from a different referring physician. And we have MDT discussion and shared decision-making in these cases between the pulmonologist and the patient.
Dr. Flores, I know this is something that tortures you sometimes. Can you give us some thoughts about when we put, by the way, within our own institution, there are radiologists that every single adenocarcinoma spectrum, you know, and I think many of us lean the other way to try and not tie the surgeons say, you're tying my hands, you know. So tell us.
I think everything is subject to human error, the radiologist's interpretation, our interpretation, and I think you got to have communication with your radiologist. So when I have a 90-year-old who's in my office and they're with their son, and the son grabs me and says, don't mention the C word to mom. And then when I have that information, I realize I've operated on this patient multiple times before. She has another thing that looks like it's on that spectrum of adeno. 90 years old, she's not going to have surgery. You know, you don't want to scare them. You don't want to. So that's when I speak to the radiologist. I say, listen, no matter what, this patient isn't going to have surgery, tone the report down. And they do it. And I think that dialogue is important. There are some patients, like we talked about earlier, when they're 55 years old and you have something there, yeah, you want them to say that adenocarcinoma. When I see that GGO that's 1.5 centimeter, no solid component, I want that 55-year-old to know, hey, that's a cancer. But like I said before, is that a cancer that's going to kill them? Right? 90-year-old, it's a different scenario. So I just think you need to have communication with the radiologist, just like with pathology. When we take out something, we go up to the pathology suite, we look at it, we have a discussion. You know, we're all subject to human error, pathologists, surgeons, and radiologists. Surgeons less so than the other two, but still.
There's a question over
that's absolutely-
Sorry, there's
That
a
was
question
subject
over
to
here.
error, that
I
kind.
think what Roger said is.
Excuse me for a second. There's a question over here.
Thank you very much. Yeah, so just to say, I practice in 2 different countries, in Switzerland and in France. And in Switzerland, typically, we don't really disclose the results of our CT to a patient because we want to protect them and manage anxiety. While in France, it's actually the opposite. They receive the report and they come to us and they say, oh, so it seems like I have something on my adrenal gland. And actually, I think the level of anxiety was kind of the same. And the more we communicate about this upfront helps. And I think also patients start to, well, I say patient because I see patient, you see participant, but I think people start to know that cancer doesn't automatically mean intervention, as with prostate cancer, for example. So maybe if we can advocate a bit upfront, that might help to lower the anxiety.
Okay. Well, there's a
But Fred, really quickly on what Raja said, I think culture is local, and that interaction between your multidisciplinary team and your surgeons, your pulmonary medicine physicians, your rad oncs, your radiologists, you come to a place where you understand how you all work together, and that impacts how we report. You know, our reports are simpatico with our multidisciplinary thoracic team. And just like you said, you work with your radiologist in certain situations, say, you know, maybe that's not the right way to report in a certain situation. But that communication amongst the team so that we're all on the same page is great. And that culture varies city to city, Midwest to New York and so on. What's the right way to communicate in the population that you're serving?
Let me add one thing too.
Sure.
To what Rob said. Because you say that 90-year-old comes in and the son says, don't tell my mom about it. But does that 90-year-old have dementia? Or does she want to make her own decisions? So that has a big play, and the son may have an ulterior motive for not telling mom. I mean, I've seen that as part of the practice.
Yeah.
So that 90-year-old can make her own determinations, as can the 55-year-old, depending on the conditions of the 90-year of age.
That's a good point, but you know that when you go in there, there's certain 90-year-olds that are sharp as a tack, tuned in. You know that when the one comes in here and, you know, she's been coming with the same son for the past 15 years, you trust that son. And when push comes to shove, I think you got to trust family. You know, rather than you jump in there, you see this patient once every year or 2 years, you don't know that patient like the family does, but it's your judgment, because there are some times where you do have a son who wants the family fortune, let mom die or whatever, but you know, you got to use your judgment.
Excuse me, but this conference is being Zoomed around the world. And we have a comment from a Zoom, one of the Zoom watchers who wants to hear what a patient thinks about this. Sheila, can you talk about the patient's perspective? Do you want to hear the word adenocarcinoma? You do, okay.
I mean, some do, some don't. I happen to want as much information as possible, but I definitely want to know everything.
See, but it's clear. You have a patient like Sheila, you know, this is what she wants. There are other patients where it's not clear, where they are a little confused, where they are, you know, dependent on that family member there. With those patients, you're a doctor first, you're a surgeon and a diagnostician second.
Right.
And the doctor part wants to make sure that patient can live the next day to the fullest. And it's up to us to make that decision. It's a judgment call. But you have someone like Sheila who's tuned in, who knows the literature, is looking straight at you. You have to tell that patient everything.
Can I add a comment here? And let's pretend that Lee and his world doesn't exist. No, we love Lee. Just, what is a report on a test, but in this case, CT scan, what is it for? Who is it for? Is a CT report for the patient, or is a CT report for the ordering physician who needs help from the radiologist to work up that individual? I think the latter. So I need the right information to be able to continue my evaluation of the patient, who I am sitting with, and I'm discussing all these issues with the patient. So I think, and I think what Ella said is very important. We know that 60+% of nodules are lost to follow-up. So we do need some red flags there when they're needed. However, do we have to go as far as to be, as a radiologist, be a pathologist and start talking about, you know, tissue type of diagnosis? When you see a pneumonia, do you say probable pneumococcal pneumonia? You don't, right? You say it looks like a pneumonia and go ahead and work it up. Do we have to say adenocarcinoma type?
Does it make a difference if I say adenocarcinoma or carcinoma?
Or yeah, possible neoplastic lesion differential diagnosis? Give wiggle room to the. Let me know that, okay, there is a possibility of a neoplastic lesion, but do we have to go into that?
So flip that. You're a patient, you've gotten this report, which you're going to get no matter what. And you're almost certainly getting it before your physician gets it. And you're going, you know, people are on the web and they're reading about these things. If I say lung cancer, they're going to get all these bad statistics about what lung cancer is. If I say adenocarcinoma spectrum, they're going to be able to they'll see that on the web, and that's different.
But
and they'll be prepared when they come for the conference.
Yeah, but if I do my job correctly, I should discuss those things with the patient, and it makes it easier for the patient to accept these things when they hear it with a physician in the room, I think.
I think the problem with the Cures Act and this automatic release of information is that not every patient is ready to receive the information. There's problems in healthcare with getting access and time to see a pulmonary medicine physician. So are they able to see you tomorrow? Are they gonna, is
Yeah,
it 2
no.
weeks, 4 weeks? So.
And then in
they need
reality.
patience.
We have a
leave
question from
doesn't-
the
does
audience.
Exist, actually.
I think is going to be more like a comment. One of the observations I had myself is there's always the matter of time. I totally agree with you, Raja, that it's all about individual aspects of the patient. And I think to you, Ella, it's also about technology is getting where we can be more definitive as radiologists. But the aspect of time remains. I've observed it multiple times that the level of anxiety of the patient is the highest before they hear whatever you say. So then it kind of goes down in despite of what it says, whether adenocarcinoma or the carcinoma. So I think we also have to keep that in mind. Sorry for that.
I just want to throw in one more. There's a Dr. Miles commenting on the 21st Century Act, and he says, but we can take the extra step of supplementing our reports with definitions of technical and medical terms and categorizing our findings as benign or probably benign when applicable to bring peace of mind to the patient reading the report.
Yeah, we do that with lung rads. I mean, we have the category and we say, this is, this is a negative screen. There's no cancer, this isn't cancer. I mean, giving that information to patients and arming them is important.
I mean, the reality is that 90-year-old confused patient is probably not looking at her own records.
Probably not.
That's the reality. You're, as a doctor, you're the last line of defense between what's going on over here and that patient. It's up to you to interpret everything and to put it in perspective for them. Sometimes there are patients who want to know the statistics. What's this? What's that? And that's a different type of patient. Most patients are coming to you as a doctor for your opinion. And ultimately, that's what they're looking for. And there's not going to be a right answer here.
I want to show you how far this has gone. Very recently, I had a patient that had multiple cancers that had been operated on already. Come back, there's scarring in the lung, there's lots of stuff. And there's like a 4 mm ground glass something. I didn't even mention it in the report because the report was already this long. I got a call from the surgeon who wrote to me to say, please put an addendum on your report to mention this 4 mm non-solid lesion. So, I mean, it's really in their minds now that, and it goes from extreme to extreme. I won't say which surgeon it was, but they're not in the room.
Andrea Wolf.
Can I ask a question to Dr. Goldsmith? Does having that language in the report that gets automatically released to the patient actually protect any of the clinical team in this setting? Let's say it's somebody who really is unreliable, they get kind of lost to follow-up. Is that protective medical? So just having it in the report sort of almost reduces the accountability of the treatment team. Like it almost gives them an out and could really impair the communication between the surgeon or the pulmonologist or whoever's seeing the patient.
Let me respond. The more information that is in the record, the better it is for the defense side in any sort of future litigation. Because what happens is that when you lose control of the patient and we gain control of the patient, okay, and I look at it that way, I want all the information that is part of the record. And the more information that is there diminishes the possibility that there is a case, or would shift it. Let's assume you have a system whereby that information is there and the patient is lost from follow-up. Why is the patient lost from follow-up? That means that somebody down the line did not do what they should have, or this patient made the decision not to be followed up. It could be either one or the other. I look back because I mentioned it yesterday to somebody. The very first case that I ever received a call on when I went out as an attorney, after I'd done my clerkship and everything else, was from the then chief of thoracic surgery at Sloan Kettering, who had a patient in his care who had been under the care of an internist, and she had been reported as having cancer of the lung. That information was never given to her. So when she went back to him a year later, she said, what how am I? He said, well, what did you do about the finding in your lung a year ago? She said, what finding in my lung? And it was not followed up, and she died 6 months later. So it was a lack of follow-up. It was not the fault of the doctor who saw it. It was not the fault of the radiologist. It was the fault of the internist who did not provide the information. So in our system that we're dealing with today, what information is getting to the person? Are they making a decision not to be followed up, or are they? And to put it into perspective, we get about 50 calls a month as potential medical malpractice cases. We accept maybe one.
Okay, we have 1.5 minutes left. Do any of the speakers want to make a last final brief point?
I would say that we should not be paternalistic and lock down in specialties about who's communicating information to patients. Patients have the right to their own information. That's the core of the 21st Century Cures Act. And arming patients with information on the whole is better than withholding that information for them. It gives them the opportunity to think about it, even if it's anxiety provoking, to ask questions about it, to be informed before they go to see their physician.
Javier, briefly?
No, I mean, I agree with everything. I keep asking the question, do we have to be that granular in terms of tissue diagnosis?
Raja?
The point is that until you have a biopsy that shows invasion and a cancer, you cannot tell someone they have a cancer. You can say high likelihood, et cetera. But when you tell that patient, or they read in a report they have cancer, and they jump off the roof of the building and commit suicide, and then you do the autopsy, you find out it wasn't a cancer. That's the point, is you cannot tell someone they have cancer
We
on a
don't get some-
radiology report. Probability, yes.
Concerning.
But that's a critical point, because especially in these lesions, when we see them and we see them year after year and they're growing, the chance of what it is under the right clinical, that it is lung cancer and that it is this adenocarcinoma is extraordinarily high. So at what point do we say, you want to use the word strongly suspect lung adenocarcinoma, or just, you know what I mean? I mean, it gets to that point where we know what it is. And so this is a really complicated area.
Final quick question to Lee. So with this era of AI over information or abundance of information for patients, your practice or your knowledge of a legal practice, has there been practice like what Roger just said, false positive causing harm, like over information, anxiety causing harm that they could damage, could prove the damage?
I've never seen a case like that. I mean, really haven't. That is not what you look at, and is not determinative of the decisions that
Is
you
it
make.
provable that I got through, 10 nights of not sleeping until I saw you? This was crazy. Why did they provide this much information?
It's never really come up as a type of situation. You just assume that the information is going to cause anxiety. And then it comes down to how you guys are handling that anxiety and how you are documenting it. Go back to the beginning. It's information and documentation. That prevents malpractice litigation.
Okay.
I think
Can I say to your point, there have been
No, I'm
studies,
sorry,
no,
but
there have been
we're
studies of
at-
radiology
we're
reports
over.
where
I've
the
been asked
ang-
to bring the session
Fine.
to an end,
Dude.
and to announce a break. I will take a final word. We took a Hippocratic oath to do no. And it's important to remember that. Thank you.